that is a very important question. Yes, now the guidelines say that all the patients who can tolerate ARNIs, who are candidates for ARNIs, who are suffering from every dysfunction, who have even ejection fraction of more than 45%, can be administered ARNIs. So all patients who are candidates for ARNIs should be administered ARNIs, and ACE inhibitors should be replaced in these patients. No, we should not wait for the patients to become unstable, and the ARNIs, as we will evaluate, can be started itself when the patient is hospitalized or even in ICU settings also. So there has been a concern among the healthcare practitioners that ARNI should be started only when the patient becomes stable, or when the patient presents with acutely decompensated heart failure or de novo heart failure. Then we should wait the patient to become dry, become eudynamic. Then we should start the patient of ARNIs. But that is a very confusing concept, that which patient to call stable. If the patient is having good hemodynamics, is having a stable blood pressure, is having good urine output, if his renal parameters are fine, then we should put these patients with ARNIs in the hospital settings also. So as far as the level of evidence is concerned, this has become a class 1 indication in patients with heart failure with reduced ejection fraction who are suffering from class 2 to class 3 symptoms, and ARNI should be used in these patients as much as possible. Now the next question that has been answered already partially is acute decompensated heart failure different from de novo heart failure? Acute decompensated heart failure is basically a heart failure in which the patient has been having LV dysfunction, some features of chronic heart failure, and has been doing well on medical therapy, is predominantly asymptomatic. He suffered some kind of insult, and then his chronic heart failure decompensates into an acute heart failure, and it becomes symptomatic. These patients are called as patients of acute decompensation of heart failure. The other class is a de novo heart failure. These patients did not have any features of heart failure in the past, did not have any evidence of heart failure in the past. Might be they were having some predisposing factors of heart failure, but now they have suffered a very acute insult like acute coronary syndrome or acute severe MR or acute aortic regurgitation. Now they are first time having symptoms of acute heart failure. These patients are having de novo heart failure.